Hey podcast listeners, Jim Siegler here. Sorry we've gone a few weeks without a show. It's been busy catching up with some life things, and lots of COVID-19 research. I know we've all been worried about this virus going around. The next couple months, we hope, will be a major game changer. But to be honest, I don't think that things will ever be the same again. As I'm reflecting on all the problems that were created by the pandemic, there's at least one that I'm looking forward to melting away. Stairs. Particularly stair-related injuries. If you're not spending your days in the emergency room, you probably don't know what I'm talking about. The thing is, as people have been working more from home, not in offices or workspaces, they're putting themselves at a different kind of risk. Compared to a year ago, we're seeing between 3 and 4 times the number of stair-related traumatic injuries nowadays. If the number of new cancer diagnoses tripled in a year, or the number of new heart attacks quadrupled, this would make the news. But it's just stairs. A neighbor of mine down the street, an ED doc, I'm not going to give his name out, he said he's seeing the same thing at a different hospital. So many ankle injuries, he told me. As a neurologist, I get to see some of the really bad falls. Someone who's tumbled down an entire flight of stairs, massive subarachnoid hemorrhage, diffuse axonal injury, cervical spine fractures. In an effort to be safer, to reduce our risk of catching the coronavirus, we've traded down for something less risky, but not risk-free. We did the same thing in the treatment of many neurologic conditions, weighing the risks and benefits of the condition against the treatment. Using seizure treatment as an example, it seems like the simplest solution, the safest thing. Start an antiepileptic. The safest thing, like when there's a deadly virus going around, staying at home. But it shouldn't be a knee-jerk response. You should think about the medication you're recommending to your patient. You should think about whether or not you should recommend that medication. Today on Brainwaves, a podcast about neurology and medicine, and all the fascinating science and history that come with it, we're exchanging one big problem for another, generally much smaller problem. COVID for stair-related injuries. Convulsions for capsules. I'm Jim Siegler, stay with us. And be careful with those stairs. Before we get started, a quick disclaimer. As with all Brainwaves episodes, what you're about to hear is intended for medical education only, and should not be used for routine clinical decision-making. We covered some basic antiepileptic pharmacology nearly 5 years ago in an older program, episode 14, Drug-Drug Interactions. So consider this as a part 2 to that program. We've organized today's show into 2 sections. First, when to start an AED, and second, which AED. So, when to start an AED. Unlike many other chronic medical conditions, seizures do not always recur or progress. 5% of the population will experience a seizure in their lifetime, while fewer than half of them will develop epilepsy. According to systematic reviews, the risk of a subsequent seizure is somewhere around 40% within 5 years of the first seizure of life. That risk goes up to 75% after a second seizure, which is why the International League Against Epilepsy, the ILAE, uses this criterion to define epilepsy and to recommend treatment. And the longer you go without seizing, the longer you'll go without seizing. According to the long-term results from the MESS randomized clinical trial, about 3/4 of patients achieved seizure freedom by 5 years, regardless of whether they were started on an AED or not. Additionally, treatment with an antiepileptic does not improve long-term quality of life, according to some lower quality data. And side effects of antiepileptic drugs are seen in 10 to 30% of patients who are prescribed them. For these reasons, antiepileptics are not recommended for first unprovoked seizure of life, according to guidelines by the American Academy of Neurology or the American Epilepsy Society. There's no question that use of an antiepileptic can effectively reduce the recurrence of seizures in patients who may have another event. It can reduce that risk by about 35%. But whether this clinical advantage is worth the risk of side effects and the lack of long-term improvement in quality of life is a discussion that's worth having with your patient. Combining all the data, the relative risk of an adverse event goes up 50% with seizure treatment. Fortunately, the majority of side effects are mild to moderate: sedation, gait instability, irritability, abnormalities on liver or renal function tests. Rare consequences like fulminant liver failure with phenytoin, Stevens-Johnson syndrome with lamotrigine, and fatal arrhythmias with lacosamide can often be avoided with close monitoring and appropriate dosing. So how do you weigh the risk of recurrent seizure against the risk of pharmacologic treatment? There's no answer to this. It's based on the discretion of the treating physician and the risks and the benefits that the patients accept. Here are some of my own considerations. First, is there a structural brain lesion that could explain why the patient had a seizure, or a lesion that would otherwise increase the risk of recurrence? And second, is there an epileptogenic focus in the absence of a structural abnormality on neuroimaging?
So the patient will lay on the table, and there's a nice soft spot for the head.
Qualitative MRI is highly sensitive for temporal lobe epilepsies, on the order of 90% sensitive when the cause is mesial temporal sclerosis. For cryptogenic epilepsies, the yield is much lower and less well understood. But if you see a structural lesion, patients with a brain lesion or injury are going to be 2.5 times more likely to have a recurrent seizure. Compare this to what we know about EEG findings. When evaluating a patient who has a normal EEG, patients with first seizure of life who have an abnormal EEG will be at twice the risk of developing epilepsy. And to be clear, when I say that the EEG is abnormal, I'm talking about focal or generalized epileptiform discharges. In adults, the routine EEG is somewhere in the neighborhood of only 10 to 30% sensitive for predicting epilepsy, meaning about 80% of patients with epilepsy have a normal study. But it's highly specific in adults, 95% specific. That means that for every 20 patients without epilepsy, only one will have an epileptiform discharge, which is an acceptable degree of certainty for a negative test. If you break down all the guideline-based data and the combined results of randomized clinical trials and observational cohort studies that evaluated brain imaging and EEG data, the 5-year risk of recurrence in somebody who has a normal MRI and a normal routine EEG is about 30%. If either one of those modalities in testing is abnormal, the 5-year risk of recurrence is closer to 50%. Surprisingly, the risk of later recurrence is not affected by patients who present with unprovoked status epilepticus, meaning recurrent seizures within 24 hours without a recovery between events. The risk of later seizures is only augmented if a patient has recurrent seizures more than 24 hours after their first event, and at that point, the patient's now diagnosed with epilepsy. So we've shed some light on data to consider when a patient has had a possible seizure event. Next, which AED to start with? You've risk stratified the patient. They have had their first unprovoked seizure, and you've determined that they're high risk of recurrence, or they have had more than one unprovoked seizure, and you want to choose an antiepileptic. Where do you start? Major considerations are epilepsy type, patient sex, use of other medications, cost, and tolerability. In that order, generally speaking. Seizure type, sex, other meds, cost, tolerability. There's a great review by Dr. Nathan Fountain from Continuum that I'll refer you to, and you can find that reference in our show notes. In first considering the epilepsy type, is it a primary generalized epilepsy syndrome, something like infantile spasms, JME, childhood absence epilepsy, and so on, a condition in which there are generalized hemispheric discharges? Or is it a focal epilepsy syndrome, meaning that seizures originate from a focal brain region, mesial temporal sclerosis, a cortical tuber, focal cortical dysplasia, an old stroke, or a metastatic lesion? Several primary generalized epilepsy conditions have specific tried-and-true treatment guidelines. JME is classically treated with valproic acid, or levetiracetam, infantile spasms with vigabatrin, childhood absence seizures with ethosuximide. Ethosux, however, has no efficacy against motor seizures, so for patients who have both generalized complex partial seizures and generalized tonic seizures, ethosuximide won't be the drug of choice. Might consider valproic acid, levetiracetam, or clobazam. Regarding the focal epilepsies, generally speaking, each of the focal seizure drugs are thought to be equivalent: carbamazepine, lamotrigine, oxcarbazepine, gabapentin, zonisamide, tiagabine, lacosamide. Most of the time, it's okay for a drug in one class to be used for a different indication. For example, levetiracetam, lacosamide, and clobazam have proven efficacy in a wide variety of seizure disorders and semiologies. But in some instances, you can't just substitute one class of drugs for another. Valproic acid, as an example, has been shown to be less effective in complex partial seizures than the focal epilepsy drug carbamazepine, according to data from the second VA cooperative trial. That said, you'll have to consider the toxicities and the side effects, not just the clinical advantages, when recommending an AED. In trials comparing carbamazepine to lamotrigine, patients were more likely to discontinue carbamazepine, and they're more tolerant of lamotrigine. While the two drugs are equally effective for focal seizure disorders, you might find that your patient's more likely to adhere to lamotrigine. And although I am only making an indirect comparison, if lamotrigine is equally efficacious to carbamazepine and carbamazepine is superior to valproic acid, then lamotrigine is probably superior to valproic acid for focal epilepsies. So, things to keep in mind when considering an AED: epilepsy type, patient sex, use of other medications, cost, tolerability. We've covered the type of epilepsy, focal versus primary generalized, and then a few of the specific epilepsy syndromes. Next, consider patient sex. Every drug can be toxic, and nothing will haunt you more than treating a young woman for seizures only to find out that they're pregnant and that the fetus has had a birth defect because of your recommendations. Valproic acid is the most severe offender, associated with a 10% risk of major fetal abnormalities, but topiramate, clonazepam, and phenobarbital are close behind, with a 5% risk. The lowest risk is gabapentin, followed closely by lamotrigine and levetiracetam. Also worth considering is whether your female patient is on an oral contraceptive. Estrogen-containing contraceptives can induce the metabolism of drugs like lamotrigine, rendering it less effective and lowering the seizure threshold, so levels in these patients ought to be checked frequently. But also, some enzyme-inducing AEDs can induce the metabolism of oral contraceptives, increasing the chances of pregnancy. Phenobarbital, phenytoin, primidone, carbamazepine, oxcarb, perampanel, rufinamide, high doses of topiramate even, so keep that in mind. Regarding other medications, we've just covered contraceptives, but any enzyme-inducing drug should be screened for in your medrec before starting an AED that could be more rapidly metabolized or could affect the metabolism of the other patient's medication. We discussed drug-drug interactions in detail back in episode 14, and more considerations on the management of women with seizures in episode 26 with Dr. Danielle Becker. In the interest of time, I'll refer you to those shows. Lastly, to consider cost and tolerability. Medication non-adherence is the single most common reason for epileptic patients to re-present with seizures. Many will also have recurrent seizures because the wrong drug was used, or because of an underlying infection or progression of their neurologic disease, but adherence should be one of the first things to come to your mind. Compared to patients who take their meds regularly, those who miss their scheduled doses are 20% more likely to have recurrent seizures, according to one study by Manjunath using a US claims database. But there are many reasons for this, like remembering to take the medication. But there's also the financial burden of the prescription and the side effects. Kind of like I said earlier about lamotrigine versus carbamazepine for the treatment of localization-related epilepsy. The two drugs are similar with respect to efficacy, but patients are more likely to discontinue carbamazepine because of fatigue, dizziness, nausea, and other side effects. Lamotrigine can also cause dizziness, but it's much rarer. And more important for lamotrigine is that the provider should counsel the patient on the rare but serious Stevens-Johnson syndrome rash. Valproic acid is another one where side effects are not uncommon. Fatigue, as with most AEDs, is common with valproic acid, as is dizziness, weight gain, hair loss, and long-term osteoporosis. Rarely there's thrombocytopenia, liver injury, and hearing loss. Phenytoin, another old but effective drug used to treat both localization and generalized epilepsies, carries the added risk of acne, gingival hyperplasia, and osteoporosis. It's probably a good idea to have a reference on hand with all these AEDs, their indications, and their side effects. I definitely have trouble keeping up with all of it. That's it for another week of the Brainwaves podcast. Thanks so much for tuning in. Before we conclude, some of you may be wondering, when is it safe to discontinue an AED in a patient who has epilepsy? Understandably, patients who are seizure-free may no longer want to take these toxic drugs, but there are no guidelines for this. Generally speaking, the longer you go without seizing, the longer you'll go without seizing. In a patient with prior seizures who remain seizure-free for 2 years, there's a 60% chance that they'll remain in remission. No further seizures. Ultimately, it's up to the patient and the provider to come to a decision as to whether it's safe and reasonable to discontinue an AED. The risk of harm from a recurrent seizure, the risk of losing one's driver's license again, or of death due to seizures, has to be very carefully considered. And in my own practice, if the patient has a high-risk seizure focus, If they have a region of cortical dysplasia or a large cortical stroke or brain tumor, and they've had several seizures in the past, I might push them hard to continue the AED if they can tolerate it. But I'm not here to give anyone advice. Brainwaves is intended to educate and should not be used for routine clinical decision-making. Use your best judgment. Consider the evidence. Think about what we discussed today and review the scientific data on your own. This week's episode of Brainwaves was produced by myself, Jim Siegler, out of Studio 3 in Philadelphia, Pennsylvania. Music for our program was courtesy of Lee Rosevear, Cellophane Sam, John Watts, Josh Woodward, and Raphael Archangel. Our theme song was composed by Timothy Dalton. Sound effects by Mike Koenig and Daniel Simeon. For more information on what was discussed, as always, please take a look at our show notes for the references to the highest yield literature on the topics, and follow us on Twitter at Brainwaves Audio. I'm Jim Siegler, and I'll talk to you soon.